Now we're gonna talk about how we approach a patient. If a patient comes with appendicitis, what we gonna do? First of all, we will order CBCB differential. It will show leukocytosis, BMP, and then we have to order a liver function because liver is very close to the appendix. That's why we have to see it's involved or not because we have to do the surgery. So we will do the FOBT, we will do abdominal X-ray, ultrasound. If X-ray normal, then ultrasound, urine analysis to rule infection, PT in every surgical patient, then NPO, IVSS, normal saline, analgesia, antiemetic, IV, sapoxetine, surgical consult, laparoscopy, often then transfer to ER or ward. After the physical examination, we have to convert the patient to inpatient or emergency ward. This is the approach for appendicitis. So, if a patient will come with bacterial arthritis, septic arthritis, so what we gonna do for that patient? So, we will order CBC same, BMP same, but because it's like infection, so we have to see blood, the septic arthritis, X-ray of the knee and synovial fluid analysis, synovial fluid gram stain culture, and then we will, what we will do then, when we order that, we will see ESR to see if it's inflammatory arthritis or not, gram stain, synovial fluid count, synovial fluid glucose, crystals, synovial fluid culture, sensitivity, synovial fluid viscosity, stat. Then what we do, we will do NPO, IBSN, normal saline, morphine for pain, acetaminophen, oral, ceftriaxone, vancomycin for septic arthritis after arthrocentesis. Consult surgery because patient with septic arthritis on the knee needs drainage. And after that, we will advance the clock and we will see that the gram stain shows gram-positive coccus in cluster. Then we will cancel IV ceftriaxone. We will do arthroscopy stat. After the procedure, we will cancel NPO normal diet, advance the clock to regulate the patient in 6 to 12 hours, consult the patient about the diagnosis. So we have to consult orthopedic consult, arthroscopy counseling. These things we have to do. After the physical examination, we have to do synovial fluid analysis. Don't wait the synovial fluid result before starting antibiotic. Do not delay surgical consult if inadequate needle aspiration. What are the treatment of non-gonococcal bacterial arthritis? Number one, synovial fluid analysis will show for bacterial arthritis. WBC is greater than 50,000, pulmonary fluid number 75 rhythm, decreased viscosity, opaque color. Initial antibody we will give broad spectrum antibody while waiting gram stain. IV third generation cephalosporin, ceftriaxone, ceftazidime. We can choose any one with IV vancomycin. Most commonly, I use ceftriaxone. If is gram stain show gram positive coccus, depend MRSA है या नहीं है. If it's MRSA, then we will give IV vancomycin 4 to 6 weeks. This is the only antibody which have to go for long term. If it's methicillin sensitive, then we will give nafacillin or IV cefazolin for 2 weeks and then 2 to 4 weeks for oral antibiotics. So this for septic arthritis, the treatment is for 1 month. You have to remember this. If we show gram negative bacillus, then we have to give IV third generation cephalosporin 14 days, like ceftriaxone, then 14 days oral antibiotic. Joint drainage. Perform in all cases using cloths needle aspiration. If closed needle aspiration doesn't provide adequate drainage, then arthroscopy or open drainage. We have to do that thing. So for cellulitis, what we have to do CBC, differentials, and we will do the X-ray of the knee and TB to see if it's TB, bone infection, blood culture. After that, we will cellulitis, very, very, very dangerous disease because it can get to septic shock. The IVSS, IV normal saline. We will elevate the leg, bed rest with bathroom pulmonary, regular diet, IV antibody. Hormonal because patient have analgesia for pain, IV antibiotic, if nauseatic, counseling, medical condition compliance. We have to do daily CBC. We have to admit patient to the ward because we are giving IV antibiotic. Percot is like a medication which is analgesic as well as it has pain reliever as well as it has some opioids in it. Um, After we give IV clindamycin, if patient improves, then we will convert into oral and we will counsel the patient and cancel IV clindamycin, IV SS normal and send the patient home. After 2 weeks, the patient come. The total duration of treatment for the patient, if we depend if it's purulent cellulitis or non-purulent cellulitis. If it's purulent cellulitis, then it means we have purulent drainage or exudate, but no drainageable abscess. If it is an abscess, then we have to do incision drainage. So MRSA is suspected if it's purulent. Then we can give the patient clindamycin, trimethoprim, doxycycline, or linezolid. If a patient is non-purulent, so what we have to do, we will, it's mean this is methicillin sensitive, we can give the same medication. But if we are going trimethoprim, we have to add amoxicillin. If we are using clindamycin, we have to add doxycycline with amoxicillin or linezolid with amoxicillin. We have to add that. We can use alone clindamycin, but we have to add for other medication. We have to add amoxicillin. If it's a severe disease, it means systemic toxicity, extensive skin involvement, failure of the initial antibiotics, failure of the initial antibiotics. So hospitalize the patient. We have to do the X-ray again. We have to do CBC, BMP, blood culture. That's why we do it earlier. So if the patient has complication or not. If MRSA is not ruled out, then we will start the patient with IV clindamycin or IV vancomycin. Uh, Supportive therapy is like elevation, hydration, treatment or underlying condition if present. Duration is treatment is like a mild disease. We have to treat the patient 5 to 7 days. But it's a severe disease, it may be required up to 14 days. Symptomatic improvement is expected within 24 to 40 years. Lack of improvement within this should prompt suspicion for antibiotic resistance or alternative diagnosis. So we have to look out the patient of cellulitis very carefully. Next is pericarditis. If a patient come with you, he has a pain, we will like dyspneic, then we will first we order pulse oximetry, cardiac monitor, BP monitor, ECG, oxygen, give patient oxygen, IVSS, examination of the main part, then we will do CBC, BMP because it's a chest infection, chest X-ray, CKMB, troponin, X-ray to rule inflammation, inflammatory causes, blood culture, echo for rule out the rheumatic heart disease. So after that, we have if the ECG shows pericarditis, then we will start with NSAID and colchicine in the first line. So this is the for pericarditis, NSAID and colchicine are first line, but for gout, NSAID and steroid are the first line. In this, steroid are added when there is no improvement in condition in pericarditis. If a patient, then after the treatment, we will charge the cardiac monitor, then we patient to ward, order ECG, X-ray before echo. Initial order should be placed at, okay. We will ask the patient to ambulate, regular diet. reassure the patient counseling, schedule follow-up in 2 weeks. And what are the treatment guidelines? NSAID and colchicine for idiopathic or viral. NSAID should be continued while patient is symptomatic with for colchicine for 3 months. Avoid NSAID other than aspirin in post. You know, after post and my pericarditis, we can't use aspirin, steroid in antibiotic or viral pericarditis that is resistant to NSAID and colchicine. That's what I said already. Steroid in pericarditis due to autoimmune disease. Steroid treat underlying cause of pericarditis, hemodialysis for uremia. Now the next case is splenic. If a patient comes with spleen rupture like left-sided or so our first spine trauma, we will see spine embolization. We will do IVSS, normal slide, pulse oximeter, oxygen beamer, same, which we do in the a patient coming with dyspnea cough, every cardiac symptom. Then we'll examine the patient. We will, because he's coming with pain on the left side, but we have to rule out pancreatitis, serum lipase, amylase, LFTs, BMP, because the patient is coming splenic, so we have to do liver laceration, everything we have to rule out, urine analysis to see if there is hematuria or not for the trauma, and we can do. So what we are gonna do? First, we will order these things, and then we will order ECG, PT, PTNR, because we know we have to do surgery in this patient. Blood alcohol, urine toxicology. If it's for female, HCG test, chest X-ray, abdominal CT. If a patient is stable, then we will do abdominal CT. NPO, surgery consider for pain, morphine, Phenergen for antiemetic. If CT is so subscleral saline, patient to ICU or ward, then we will convert the patient to Foley catheter to monitor urinary output, cancel cervical spine. And then after the surgery, uh, if the patient remains stable in 24 hours, then we can send the patient to home. Okay. What is the approach for this patient? What is the counseling? Avoid contacts for no alcohol, no smoke, seat belt use. Okay. So in the trauma patient, we do A, B, C, D, E. Then we will order CBC, blood types, green LFT, amylase, lipase, urine IBGs, BMP, UCG, spine, XHS, abdominal CT, also have stable, alert, and non-toxicated person, abdominal CT with contrast. If no abdominal, observe and perform CT. If abdominal injury, hemoperitonia, hospitalize and consider conservative management of acute or immediate laparotomy depending on the extent of injury and quantity of blood loss. A unstable, unconscious, or intoxicated person proceed with abdominal ultrasound or diagnostic peritoneal lavage is an alternative. If there is no intraperitoneal hemorrhage, perform abdominal ultrasound, then manage as above. If there is intraperitoneal hemorrhage, perform immediate laparotomy. Surgical consent should be obtained in all cases. Okay, if either are stable or not stable, you have to consult the surgeon. Next case is of dysfunction uterine bleed. If a patient come with female come with dysfunctional uterine bleeding, we have to do some pregnancy test, ABC, RI test, and what other tests we can do? We have to do um, bleeding disorders, PD, platelet, and we have to do serum prolactin because it can also cause this. And then after, we will send the patient to home and she will come with all the result. Then we will see in the CBC, she will have anemia. Then we will, because she will come with bleeding, then we will provide OCPs, low estrogen, low progesterone, continuous inhale, not high dose. Iron, because she is anemic, consult the patient about this and schedule an appointment 3 months. Because we rule out everything and the patient doesn't have anything. No order. Ironically, we consult the patient about medication compliance, safe sex, regular exercise, simple use. Follow up in 3 months. Pregnancy should be ruled out before initiating therapy. And what are the guidelines for dysfunctional uterine bleeding? Rule out pregnancy. TSH prolactin rule out endocrine disorder. CBC PT related to rule out bleeding disorder. Diagnose anemia. Other tests would, if we can use endometrial biopsy in premenopausal women to rule out endometrial carcinoma, we can use pelvic ultrasound for suspected PCOS or vaginal tumor, but in cases optimal pelvic examination. LFTs to rule out liver disease in high-risk patient. Mild, we do only iron supplementation. If it's moderate, like 10 to 12 hemoglobin, then we iron and we can give progesterone only OCP if the patient is not actively bleeding. If the patient is actively bleeding, then we have to give OCP. Severe, we can hospitalize the patient, we can transfuse as needed. Hormonal therapy. Hormonal therapy. Combination OCP with high estrogen is stable. So when there is a very severe, like 10, less than 10, then we very severe bleeding, IV estrogen if unstable. DC and surgery are rarely necessary. These are very rarely necessary. If a patient comes with Turner, what are we gonna do? The patient comes with Turner, same, we will do CBC, we do blood culture, we will do, why will do blood culture, no blood culture. We will do serum FSH, LH, beta HCG, carotid analysis, then we will send the patient home, we will call her again, then we will see that Turner is diagnosed, FSH levels were high, then we will order fasting glucose, BMP, normal urine analysis, lipid profile, TSS, because Turner patient have high chances of horseshoe kidney, renal ultrasound, pelvic ultrasound, to see the ovaries, to rule out cardiac condition, echo skeletal survey, hearing test. These tests should be ordered as routine. Hormone therapy, we will order the patient, estrogen, progesterone therapy, oral, vitamin D, calcium, and dietary consult with bowel failure, psychiatric consult, if estimate the IQ, counseling, schedule the patient, what we consult the patient, regular diet, regular exercise, medication compliance, parent counseling. So what we are gonna do with the patient with hormonal therapy is an initiative for height below 5th percentile and is continue until epiphyseal closure. A combination of growth hormone and anabolic steroid oxandrolone is recommended for children 9 to 12 years of age. Estrogen replacement therapy is started at 12 to 13 years of age. For age greater than 13, combination OCP can be started until the menopause. So before that, because we can order only estrogen. Vitamin D and calcium to prevent osteoporosis, a dietary consult, ophthalmology consult to screen for ophthalmology, anomalies like amblyopia, strabismus, ptosis, paparopia, red-green color blindness, OBS and gynae consult to evaluate for gonadal dysgenesis, resection for prevention of gonadal cancer because there is a high risk of gonadoblastoma in mosaicism 46. 5, 6XY or 45X naught, or 8 for IVF in patient design. Pregnancy, consult patient regarding exercise, medication compliance, a prepared outpatient follow-up. We have to early physical examination, check for hypertension, monitor goals, early fasting glucose, diabetes can develop diabetes, LFT, liver enzyme, liver profile, early urine analysis to screen for UTI, anomalies are not in a nation renal ultrasound. Then we will do an early urine analysis, audiogram every 3 to 5 years, echocardiogram every 2 years, DEXA scan in adults every 3 to 5 years because they are very prone to bone loss. So if the patient comes with menopause, we have, because if the patient is 45 above, then we don't do any tests. We know that this is that's menopause. So we don't have to do tests. We will order estrogen progesterone therapy, regular exercise, high calcium diet, low salt diet, medication appliance, medication side effects, hormonal replacement therapy. We will follow up the patient. Menopause is usually a clinical diagnosis and no diagnosis testing is required to confirm that in this patient diagnosis is made following the physical examination. Uh, Vitamin D, calcium. We can order pap smear, mammography, colonoscopy, liver profile for as routine. The patient have gout, I missed the topic. We have to do the same tests like gout, foot. So we will do CBC, BMP, PT, PTR, ESR, serum uric acid. Uh, to rule out septic arthritis, we have X-ray of the foot, serum uric acid, anomalous analysis to X-ray because we rule out bone infection, counseling, NSAIDs, and low protein diet, no alcohol, no smoking, no aspirin, medication compliance. And the medicine we will give the patient. What are the approach for acute gout? We do limited test, microscopic examination, NSAID, naproxen, endomycin, other drug of choice. If there are no contraindication like renal failure, heart failure, pelvic ulcer disease, NSAID allergy, when NSAIDs are contraindicated, use just what I told that we have to do steroid, intraarticular oral steroid, when NSAID and steroid can't be given administered colchicine, but be aware of the high incidence of side effect with colchicine like GIT, side effect diarrhea, abdominal cramps, nausea, vomiting. Allopurinol should be not be administered during acute attack. Prevention of recurrent cough. Patient with typical gouty arise are usually an outpatient patient. The appropriate follow-up. All patients with gout should be advised to avoid aspirin and diuretic as this amount of alcohol and purine is food. However, these patients recommend weight loss through diet and exercise.